Hello, today I would like to talk about the intersection between diabetes and heart failure, focusing on heart failure with preserved ejection fraction, and I'm going to discuss treatment. Now, if we think about treatment, we can think about treating patients with type 2 diabetes to prevent the development of heart failure, and then we can think about how do we treat diabetes in patients with established heart failure. So where we are today really is about prevention. We've got a lot of information about glucose-lowering therapies and the prevention of the development of heart failure. We don't have any robust information for the older glucose-lowering therapies, metformin, sulfonylureas, and insulin, but we have a lot of information about some of the newer glucose-lowering therapies. And I'm going to start with the dipeptyl peptidase 4 inhibitors, DPP4 inhibitors. These are drugs that actually seem to have no benefit with respect to prevention of cardiovascular events. And as you can see here in the panel on the right of this slide, in particular, there is no evidence that DPP4 inhibitors reduce the risk of developing heart failure. However, we do have evidence that two of the other novel glucose-lowering classes of drugs reduce the risk of heart failure. We've got robust evidence for the SGLT2 inhibitors, and we've got perhaps promising evidence for the GLP-1 receptor agonists. So let's look at the SGLT2 inhibitors. Here is a meta-analysis of the three large trials in patients with type 2 diabetes and either established cardiovascular disease or cardiovascular risk factors. And you can see that whether you look at people who've just got risk factors or you look at people who've got established cardiovascular disease, there is a clear reduction in heart failure hospitalization with this new class of treatment. And these findings have recently been supported by a further trial carried out in patients with type 2 diabetes and chronic kidney disease. And we know that patients with type 2 diabetes and chronic kidney disease who are excreting increased amounts of albumin are at particularly high risk of developing heart failure. And indeed, that was what was shown in this trial called Credence, and in patients in the Credence trial, the risk of heart failure hospitalization was reduced substantially, as you can see here, by 39% with an SGLT2 inhibitor. So really we have four very large trials convincingly showing that SGLT2 inhibitors reduce risk of developing heart failure hospitalization. What about the other new class of glucose-lowering therapy, the GLP-1 receptor agonists? Well, until recently, we didn't have convincing evidence that these agents do reduce the risk of developing heart failure. This is one of several meta-analyses showing a trend, but nothing significant. But recently, we had another GLP-1 receptor agonist trial. In fact, the fourth large GLP-1 receptor agonist trial report, the Harmony Outcomes trial. And in that trial, in around 9,600 patients, there was a reduction in the standard MACE cardiovascular composite endpoint, as you can see in this figure. But of more interest in Harmony Outcomes, there was also a significant 29% reduction in risk of heart failure hospitalization. So that may change our view about whether these drugs can prevent the development of heart failure in patients with type 2 diabetes. And indeed, we're going to get more evidence on this class of drugs very soon, so the picture will become clearer. There's a very large trial called REWIND that will report shortly at the American Diabetes Association Congress, and this trial, we already know, will show that there is a reduction in the risk of cardiovascular events. And there is another trial that we will hear about in the not too distant future called Pioneer 6, which is also reported to show cardiovascular benefit with a GLP-1 receptor agonist. So more information coming, the picture will become clear. And indeed, there are many new trials with this class of treatment getting underway, a sort of second wave of trials, which are summarized in this slide. I'll just highlight the second one down on this list, the SELECT trial. This is a trial that's actually being conducted in patients who are obese or overweight, but who do not have diabetes, because, of course, GLP-1 receptor agonists also lead to weight loss. And we know about the association between obesity and HFpEF, and therefore this is a particularly interesting mechanism of action of these drugs. But what none of these trials to date have done is to characterize well the heart failure phenotype in patients who are hospitalized during the trials with heart failure. We really don't know whether these patients have HFpEF or HFrEF. So there's more work to be done to characterize exactly what type of heart failure it is that's being prevented by these treatments. So let's turn to the other side of the coin. What about patients with established heart failure, particularly heart failure with preserved ejection fraction, who have type 2 diabetes? What do we know about the glucose-lowering therapies that we can give to these patients? Well, the answer is that we really know very little. In particular, we know very little about whether the drugs that prevent heart failure are beneficial in patients who have established heart failure, and that's an assumption that we must never make. So an example of why that assumption can't be made is given on this slide. If you look at calcium channel blockers, a very effective treatment for hypertension, they reduce the risk of developing heart failure, but you would not give a calcium channel blocker to a patient with established heart failure, certainly not a patient with heart failure and reduced ejection fraction. So let's look at what we're trying to do with our treatments that lower glucose in patients with type 2 diabetes who also have heart failure. And I think we probably have three major goals. We want to prevent, if possible, progressive worsening of the heart failure syndrome. We want to prevent progressive deterioration in renal function. And we want to prevent the development of what our diabetology colleagues call microvascular complications, things like diabetic eye disease, diabetic peripheral neuropathy, and autonomic neuropathy. Another desirable goal of treating patients with HFpEF, of course, would be to prevent the development of diabetes in the first place, and I'll come back to that in a moment or two. So what do we know with respect to the treatments that we talked about when we discussed the prevention of the development of heart failure? Well, we don't know much about DP4 inhibitors. There has been no large trial looking at these drugs in patients who have established heart failure. So we're really reliant on subgroup analyses of the large trials with all the limitations of those. And unfortunately, the same is also true of GLP-1 receptor agonists. There are a couple of small trials that actually, if anything, tended to show an unfavorable effect of these agents on heart failure outcomes, but small numbers, not robust information, and again, we're reliant to some extent on subgroup analyses of the large studies that I mentioned earlier. So really not much information. We have a bit more information about the SGLT2 inhibitors and are going to get a lot more information. So here is that meta-analysis again of the three large type 2 diabetes SGLT2 inhibitor trials. And at the top of this figure in the upper panel are the minority of patients, the around 15% of patients who had heart failure at baseline in these trials. And you can see that those patients who had baseline heart failure seem to get roughly the same risk reduction in heart failure hospitalization. The problem, of course, is that we don't know what type of heart failure those patients had at baseline. But we are going to find out a lot more about these treatments in heart failure because in HFpEF, there are two large prospective morbidity mortality trials underway with SGLT2 inhibitors, which, by the way, include patients with type 2 diabetes, but also patients without type 2 diabetes. So a lot of people have asked why have we included patients without type 2 diabetes in these trials. And really there are two considerations here. One is that these drugs may have benefits that are not glucose dependent, and this figure summarizes some of those speculative mechanisms. None of them are really proven, but there are lots of interesting hypotheses. The other reason why we've included patients who don't have type 2 diabetes in those HFpEF trials is because amongst the remainder of patients, the majority have pre-diabetic dysglycemia or undiagnosed diabetes. And you can see in this figure, which shows both HFrEF and HFpEF, the blue segment of these pie charts shows you the patients with a normal hemoglobin A1C. They are the small minority. Less than a fifth of our patients with heart failure have a normal hemoglobin A1C. Now, I said there are a couple of other goals. One is to prevent progressive worsening of renal function, and this figure taken from the Paradigm heart failure trial shows that patients with heart failure and diabetes have much more rapid and a much more steep decline in eGFR over time than patients without diabetes. So clearly we would like to reduce that progressive deterioration in renal function. And the good news is that we can do that. We can certainly do it with SGLT2 inhibitors, as shown in this meta-analysis, and probably also with GLP-1 receptor agonists. So in our patients with HFpEF and diabetes, I believe that these treatments will help us reduce that risk of rapid deterioration in renal function. And we should also obviously try and reduce other microvascular complications in patients with type 2 diabetes and HFpEF. We know that glucose lowering, probably through any mechanism, whatever drug you use, is likely to reduce microvascular complications. And that's important in general, but it's perhaps particularly important in patients with heart failure because, as you can see from this sub-study from the TOPCAT trial, patients with diabetes who also have microvascular complications are at particularly high risk of events, even higher risk than patients with type 2 diabetes without microvascular complications. And finally, I mentioned that it would be desirable to prevent diabetes in the first place in these patients and all the complications that go with diabetes. And in those two large ongoing morbidity mortality trials, we'll be able to look at whether SGLT2 inhibitors do this because, of course, we've included patients who don't have diabetes at baseline, and we will be able to monitor the development of diabetes over time and see whether that's reduced by experimental therapy, SGLT2 inhibitor treatment. So to summarize and conclude, it's an amazing time in terms of developments in diabetes and developments in heart failure as well related to glucose-lowering therapies. We now have overwhelming evidence that SGLT2 inhibitors reduce the risk of developing heart failure, and we're finding out in two new trials whether these agents can be used to treat heart failure, patients with heart failure and preserved ejection fraction. We're also going to find out whether these new glucose-lowering therapies might even be of benefit to patients with HFpEF who don't have diabetes. We'll find this out in those ongoing trials. Unfortunately, we don't know about the other novel glucose-lowering therapies, and we really have to try to do more studies to find out about the safety of those agents. So thank you very much.